Right, good afternoon. Yes, it is good afternoon. Mr. Gale.
Thank you, my Lord. The next witness, my Lord, and final witness for today is Eileen McKenna. Her witness statement is SCI WT 0459 and then 501. Mrs. McKenna, your full name, please?
Eileen McKenna.
Yes. Your details are known to the inquiry and you provided us with a detailed statement, and together with the evidence that you'll give orally today, you are content that that be the evidence you provide to this inquiry?
I am.
And I think you're also prepared that that evidence be recorded and transcribed?
Yes.
Again, I'll make the point, Mrs. McKenna, that there will be certain parts of your statement that I won't touch on in the course of this oral presentation this afternoon. But please be assured, and your colleagues also, that all that will be taken into account. In your case, there is actually, I'll give notice of it now, there is quite a large section dealing with education and
yes.
certification, which is something that falls within your ambit, and we'll come to your role in a moment. And if I can just tell you that while it's a section which I and my team will have regard to in looking at impacts, it is primarily an issue which falls within the ambit of the work being done by certain of my colleagues in the inquiry. And they will be dealing with education at all levels. And they will be specifically considering the issues that you raise in the education section of your statement.
Okay.
Now, you are the Associate Director for Nursing, Policy and Professional Practice at the RCN, is that right?
I am, yes.
And you tell us a bit about that post at paragraph 2 of your statement, which we can read. And you've been in that position since October 2018.
I have, yes.
So it's a position you occupied during
yes.
the whole of the pandemic.
Yes.
You provided us also with details of your clinical experience at paragraphs 4 and 5. And again, we can read what you say there. And at paragraph 6, you, and following really, you talk about the role that you had as the representative of RCN Scotland from the early weeks of the pandemic.
Yes.
Could you just explain that briefly, if you would?
So mainly within the first weeks of the outbreak. So the RCN is a UK organisation, but because of the devolved nature of health, there are 4 countries, so Scotland, Northern Ireland, Wales and England, and at the outset of the pandemic, senior staff from across the organisation came together and established a 4-country senior group so we could look and address issues which members were encountering whilst working in hospitals, academic settings or social care settings. And our purpose was to monitor the emergent situation, the policies or the different policies across the UK and the guidelines that were being published, and ensure that our members were provided with up-to-date evidence-based information. We also tracked and responded to issues that were raised by members through RCND and other means across the 4 countries. So we looked at trends and themes that were coming out and sort of major issues that we needed to give support and advice to our members on.
Now, we've heard from Mr. Pullman about some of those issues, and you've, again, very helpfully listed them in paragraph 8 of your statement. Can I ask you about a couple of them, please?
Yes.
Firstly, the section that is headed Members at Risk, and in particular those who were pregnant and had underlying health problems. Can you just give us a little more context to that, please?
So at the outset of the pandemic, it became clear that there were groups of the population that may be at higher risk from COVID infections and the impact on their well-being, particularly pregnant mothers. So clearly, with nursing being a predominantly female population, there are many nurses who are pregnant and working during their pregnancy. So quite a number of our members were concerned about what was in the media around the impact on pregnant women. You know, the government had said pregnant women should shield quite early on. So in terms of the impact on them and their employment, I would say the majority of employers took cognizance of the risks and did allow pregnant members to shield, but some didn't and needed a bit of prompting to respond to the guidance. And it was about, you know, if you are sick during a pregnancy, it can trigger early maternity leave, and that can have financial implications. So it was making sure that they weren't financially disadvantaged, as well as being protected by being allowed to shield.
Right. And underlying health issues, I suppose that's self-explanatory.
Yeah, you know, nurses who were diabetics or maybe had conditions that meant they were immunocompromised. So if they were on steroids for any underlying health condition, clearly that increased their risk of contracting COVID and having severe effects of COVID.
The second category of themes that I'd like to ask you about are personal issues. This obviously is a bit of a catch-all, I suppose, isn't it?
Yes, I mean, it is a catch-all, but I mean, examples, you know, travel issues, guidance due to travel restrictions. Some members travelled a distance to get from home to work, and because of the travel restrictions, that meant that they potentially couldn't travel those distances. For example, staff working in the community would car share to get to a patient's home, and there was lots of issues about whether there should be car sharing because they couldn't socially distance in a car. So there was lots of issues like that we looked at and either lobbied the governments to clarify their guidance or give information to members.
Mm-hmm. So just to understand, RCN Direct was a platform where your members could express their concerns about various, possibly very specific issues.
Yes.
And obtain information?
Yes, so RCN, so we met daily at the outset of the pandemic, the senior group, and the senior member of staff from RCN Direct would come with a report on the previous day's calls. So we would compile themes and look at the types of issues that were being raised. Were they particular to a certain geographical area or employer, or were they generic themes across the UK or within the 4 countries of the UK individually? And then we would work to develop guidance or take action in terms of feeding back to our retrospective governments to get the guidance changed.
Would these be matters upon which you as a professional organisation would offer advice to members, or was it really a talking shop where you could take material to the persons who were responsible for formulating guidance and make representations to them?
It was both. I wouldn't say we were a talking shop. It certainly didn't feel like that. So we would work to either, I brought the information back, so we met from a UK perspective early in the morning. We reviewed the issues from the day before, and then we would meet as a Scotland team, and I would bring particular issues back that, say, my colleague Norman Proven would pick up from an employment relations perspective, or I would pick up in terms of the guidance that staff were having to adhere to, and pick that up either through myself or through the then director of RCA in Scotland at the time, with Scottish Government or other stakeholders. So, but we did publish our own guidance as well. We would look at the evidence base and publish guidance for members.
Thank you. You were also a representative of the RCN on several Scottish Government groups, which you list in paragraph 9. Mm-hmm. Can I ask you about CPAG?
Yes.
Please, can you just tell us a little about that?
So CPAG, the Clinical Professional Advisory Group, was a group that the Scottish Government established to respond to the many issues that were coming out from the care home sector. The group had wide representation from the care home sector and other stakeholders, including ourselves. It was a multi-professional group, so it didn't just address nursing issues. There were medics on the group, AHPs and others. So it was to address many of the issues that were being raised by the care home sector, but I suppose the main function of it was to give that sector a voice and enable them to influence and the Scottish Government around the guidance and etc. and the conditions within care homes, whether they were the conditions for residents. So there was lots of consideration around the guidance around visiting, for example. It wasn't a decision-making body. It was a body that the stakeholders could have their input and influence some of the decisions that were being made.
Yeah. So it wasn't a decision-making body. What was its substantive function?
Influencing. So influencing decisions.
Because I think one of the points you've made, and your colleagues have also made, is that while you as a professional organisation had a place on many of these committees and groups, you at no stage had a right of veto.
No.
Is that right?
No.
And so, to a certain extent, influencing was probably the heightened tool that you had available to you.
Yes.
Okay. Can I move on to consider with you the impact on your members of the pandemic, and particularly the pandemic planning carried out by the Scottish Government? And in this context, you in your statement looked specifically at staffing levels.
Yes.
At the outset of the pandemic. And if one goes to paragraph 14, you say that those within the nursing profession have and continue to work under sustained heightened pressure, and this has a significant impact on the physical and mental health of nurses, and this has a collateral effect on the quality of care being delivered.
Absolutely.
Can you explain that, please?
So the RCN has been concerned for a number of years around the levels of nurse staffing, both within the NHS and within the care home sector. I have to say from the outset that Scotland is in a unique position in terms of the data that is publicly available through around the NHS workforce, and we do use that data significantly to lobby and influence Scottish Government on workforce issues. However, I think the data highlighted that pre-pandemic there were concerns around the number of vacancies, vacant posts, nursing vacant posts across Scotland, and prior to entering into the pandemic, there was a growing crisis in the nursing workforce. And if nurses cannot provide the care because of staffing levels or etc., that they feel or know that the patients require, that can have a detrimental impact on their own well-being in terms of that sort of moral injury, moral distress, because they know that they're not delivering care to the standard that is required.
Mm-hmm. And to the standard that they would wish to do.
Absolutely, yes.
Yeah. Perhaps you summarise it in the last 2 sentences where you say, put shortly. Perhaps you could just read those 2 sentences, please. Paragraph 14.
Put shortly, there are simply not enough nursing staff to provide the level of care that our population needs now or indeed before and during the pandemic. The impact this is having on our members is a situation that RCN Scotland has been gravely concerned about for some time and well before the pandemic hit.
So this is a pre-existing problem.
Yes, not only, I need to emphasise it's not only in the NHS. Prior to the pandemic, the RCN in Scotland was lobbying the Scottish Government and other stakeholders to value registered nurses within the care home sector. The number of registered nurses within the care home sector had been declining prior to the pandemic, and through work that we did in around about, work we did in 2018, highlighted some concerning nurse to resident, and I'm talking about registered nurse to resident ratios. Sometimes registered nurses could be the only nurse within a care home for, I think the worst case I'd heard of was 120 residents.
So this was a across the board problem.
Absolutely, yes.
You provided us with information and very helpfully given us the various data sources for that information in paragraphs 15 and following of your statement. And clearly this is something that we will be looking at. And this has informed you, as I understand it, as to the adequacy of staffing, both within the NHS and in the social care sector.
Yes.
So could you just perhaps summarise your conclusions having looked at this data?
So this paragraph looks at data between December 2015 and December 2019, which did show that within the NHS the nursing workforce did grow by 2.7%, so from circa 41,000 to over 42,000 whole-time equivalent staff. However, the upward trend was also reflected in the number of vacancies, and the vacancy rate continued to rise steadily, including long-term vacancies, so posts that were not filled for 3 months or longer. And at that time, the planned establishment, the number of staff required to meet the clinical activity across the NHS was actually never achieved, with vacancies rising from 1,600 to 2,600 over that time period. And that was NHS data alone. The care home sector data, as I say, it's not as robust as the NHS data, but it did demonstrate that over that period of time, there were 380 fewer registered nurses in care homes for adults.
Yeah. And, well, it perhaps obviously follows from what you've said that the pandemic did not serve to cause that deficiency in staff.
No, I would say it's probably made it worse, but yes, the deficiency was there.
Was there? Mm-hmm. Yes. Yeah. Now, at paragraph 17, you tell us about a survey that the RCN carried out. And what were the results of that?
So the RCN carries out a survey regularly, annually, and so the November 2019 we published a report that highlighted that members across Scotland, whether they work in the NHS, GP practices or care homes, were feeling overworked and under-resourced and undervalued. So 2/3 reported they were too busy to provide the level of care that they considered necessary, and they didn't feel that their contribution was valued by those in a position of power. I would say lack of being valued is a recurring theme from feedback from our members, and that is.
I'm sorry.
And that's deteriorated during and after the pandemic.
When you say not being valued, and you attribute that to those in positions of power, who is that directed against? So
that was directed at the governments of the UK. I think one of the key themes that comes out and from feedback from our members is that nursing as a profession doesn't necessarily get the same recognition of the critical safety nature that registered nurses provide. There is international evidence that registered nurses, if they're in the right number with the right skills, impact significantly not only on the quality of care, but they reduce mortality and morbidity. And if those numbers are insufficient, that clearly has the opposite effect on not only quality of care, but mortality and morbidity.
Right. Throughout this part of your statement, you punctuate what you have to say with quotations from various sources. Can you tell me where they came from?
So, some have come from our surveys in terms of the free text that the nurses have chosen to enter into the survey. The majority of the quotes within my statement come from a system called SenseMaker, and we started collecting that data, so that captures the lived experience of nurses over time. So both qualitative and quantitative data. So we started that in October 2020, November 2020.
And are these quotes intended to demonstrate typical responses from some of your members?
Yes, so I analysed the data from our Scottish members, and in fact, up until last year, it was only RCN Scotland and RCN Northern Ireland that were using the system. So I would say I read every story that nurses have entered into that system, and I've taken themes, the key themes, and used individual stories to illustrate the points.
You tell us in paragraph 17 that almost 2/3 reported that they were too busy to provide the level of care that they considered necessary.
Prior to the pandemic,
Prior
yes.
to the pandemic. How robust do you think that is as a comment on the health service at that time?
I think it's fairly robust in terms of our membership is significant. I think my colleague, Mr. Pullman, highlighted the size of our membership. We are the biggest nursing-only organisation in Europe. I'm looking to my colleagues to confirm that. So in terms of the size of our responses to surveys, they're significant and fairly representative of how nurses view their working environments across the UK.
Would you read the quote at the bottom of paragraph 18, bottom of paragraph 17, please?
Yes, so the most upsetting and stressful part of my job is being unable to give good patient care due to poor staffing levels. And unfortunately, it has become normal to work under this constant stress. Never have I felt pressure like this in my career and have never felt so undervalued. So that was from a Band 5 nurse in a hospital in Scotland pre-pandemic.
Now, there was also, as you point out, a rise in registered nurses as staff delayed retirement or returned to work. And I think you indicate that on the one hand, had a positive aspect to it, in that they felt that they were, as you put it, doing their bit, but also a downside where they felt that their skills were not being appreciated.
Yes.
Can you explain that latter, the downside, rather than the upside?
So as an organisation, we set up, when the call went out for nurses to consider coming back to work, they did respond across the UK in their thousands. So we knew from our members that there was varied experiences. So we set up a network to engage with nurses returning, and I'd say the feedback was mixed, but in many cases, nurses returned to maybe clinical areas that they had recently left. And I think the example I give in my statement is a nurse who was a Band 6, so a charge nurse level, had recently retired from a clinical area and volunteered to return weeks after leaving for her retirement, and was interviewed for the post and then placed on the bottom of the Band 5 salary, but clearly was coming back to work with the skills that they'd had prior to retirement, and was expected to work at the same level as they did but prior to retiring. Yeah.
Obviously, the need of staff to self-isolate exacerbated the problem, as you point out.
Yes.
One of the points that both you and your colleague, Mr. Pullman, made is the question of situations where staff were redeployed into roles that perhaps were not familiar to them.
Yes.
Do you have a comment on that?
So I think in terms for planning for the impact of COVID on the acute hospitals primarily, staff were not only redeployed, so a number of staff, there was a need to increase the intensive care capacity. And in order to increase intensive care capacity, you need to increase the number of staff that clearly work in intensive care settings. For example, intensive care, so I am an intensive care nurse by background and did an additional year's training and education to work within that environment. And it is different knowledge and skills that are required from, say, an acute medical or an acute surgical ward. It's a completely different set of skills that are required, and to move people quickly into that environment. And I'd have to say, even the staff who worked in intensive care, I worked here for well over 10 years. I never experienced anything like the staff who worked in ICU during the pandemic. This was a new illness, and it had, a significant mortality rate at the outset of the pandemic. So the conditions that they were working in were extremely stressful, and for staff to move into that environment, not having the benefit of years of experience of working within intensive care, was clearly very, very stressful. Yep. So normally nurses in ICU would look after one patient, and they would have a senior nurse and medical staff supporting them with that one patient. So somebody, a nurse at a much more senior level with advanced skills would be there to support them. We knew that during the pandemic, one ICU nurse could have responsibility for 4 patients and supervise non-ICU nurses or even other healthcare professionals, like some medics were redeployed to ICU to work as in a nursing capacity, or AHPs were redeployed in. So the pressure on the ICU nurses was immense, as well as those that had been redeployed into that area. But for nurses in other areas, wards were changed from, say, medicine for the elderly to COVID wards, and that's a completely different set of skills. Surgical wards were changed into medical wards. There was a complete redesign of services, and not just in acute hospitals. Even nurses who cared for, say, patients with learning disabilities in an outpatient setting, that had to change. They had to meet the needs of those patients in a different way because of clearly those with learning disabilities were shielding, so they had to deliver services in a completely different way than was the norm.
I suppose one might say that in some, if not all of those situations, it was a case of needs must.
Yes, yes.
But while needs must, was there, you say, a detrimental effect on the well-being of the nurses who were having to do that?
Yes.
But also, was there, in your view, any detrimental effect on patient care?
I think undoubtedly yes, in terms of you need a level of expertise, and staff were maybe not working within their own level, their own expertise. They were being redeployed or working with a different client group than would be their norm.
One of the points you make, and I think it's possibly one that is perhaps, or has been perhaps, slightly underplayed, is the level of aggression and violence that was demonstrated towards nurses. Is that fair to say? That it's something that's been underplayed?
Yes, it was something that nurses reported increasingly as the pandemic went on, in terms of the level of violence and aggression that was that they were experiencing, and I think we need to recognise that people were frustrated, anxious if they had a family member within a hospital that they weren't allowed to visit, or within a care home that they weren't allowed to visit. But nurses didn't make that guidance, they didn't make those decisions, but were often at the receiving end of those frustrations.
Yes. And I think you've given 2 quotations from nurses.
Yes.
In relation to that, and we can read those. Would you go to paragraph 29, please, of your statement, which I think is effectively a conclusion in this part of your statement. Would you just read it out?
So,
29.
Sorry.
Yes,
The quotation or
No, just with the text of
right.
from 29, from the
From
figure 29 onwards.
The impact of the government's pandemic planning on RCN Scotland members cannot be understated. The above illustrates the demands felt on RCN members throughout the pandemic, which were exacerbated by a depleted and overworked workforce. It is imperative that the Scottish Government considers a structured approach to workforce planning that ensures that we have the right number of registered nurses and nursing support staff with the right knowledge, skills and experience in the right place at the right time, should we be ever faced with a future pandemic.
And that's obviously your considered view.
Yes.
From your perspective and on behalf of the RCN.
Yes.
Any reason to depart from that?
None whatsoever.
Thank you. Right, can I now ask you to go to paragraphs 35 and 36 of your statement, please, in relation to PPE. You set out the guidance on PPE that was issued by the Scottish Government in March 2020. What you indicate is that this was guidance that the RCN strongly disagreed with. Can you take us through that disagreement and the eventual resolution, if there was one, of it?
So, at the beginning of March 2020, the guidance for PPE was that in any setting where there was a suspected or confirmed case of COVID-19, that the PPE that should be worn by staff was an FFP3 mask, long-sleeved fluid-resistant disposable surgical gown, 2 pairs of sterile gloves and iron face protection. That changed in the middle of March 2020 to a table that set out different PPE requirements for different settings. So, for example, ICU areas, it was the full PPE as described, but in non-critical hotspot areas, the PPE was a fluid-resistant surgical mask, disposable plastic apron and disposable gloves, required when working in a room or a cohort area with suspected or confirmed cases of COVID-19. If not in direct contact, i.e. within 2 metres of a confirmed or suspected case, then no PPE was required. So there was the situation where you could have a bay of 6 patients and there was yellow tape put at the end of the bay, and if the nurse was on one side of that tape, did not have to wear any PPE, and on the other side of that tape were required to wear a fluid-resistant surgical mask, plastic apron, and they only wore the face visors if there was a risk of splashing from bodily fluids. Our contention at the time of that change was that was insufficient protection for the staff working within clinical environments. The guidance was changed frequently, and it did eventually change that within a hospital or care setting, or for community staff going out to people's homes, that they needed to wear a fluid-resistant surgical mask at all times. Our contention was that the guidance was based on the belief that COVID-19 was droplet transmitted by droplets, where the RCN has always considered that the science around that was not proven to begin with, and therefore, in terms of the balance of risk, it should be considered airborne. And as you heard this morning, the RCN was part of an alliance, a coalition that looked at the international evidence, and that our contention that COVID-19 is airborne. Has been proved correct. We also, there was lots of research studies coming out from countries across the world, even prior to the pandemic hitting the UK. And if you look at comparisons, the actual infection rate for hospital workers was reduced in countries that took a more precautionary approach to PPE and respiratory protective equipment, i.e. FFP3 masks, than, say, the infection rate within the UK. And if you look at the comparison between, even in the UK, those that are working in critical care areas had no higher than the general population's incidence of COVID-19, but those who worked in other clinical areas had a higher incidence than the general population of COVID-19 infections.
You say that there was a disagreement between you and the Scottish Government, and the Scottish Government persisted for some time in basing its PPE guidance on the contention that COVID was droplet transmitted. Was that an area of particular frustration to the RCN?
Yes. So not only was the reliance on the assumption that it was droplet transmission, but also the hierarchy of infection control. So the 5 different levels, so that you could reduce risk by ventilation, social distancing. Social distancing doesn't work for nursing staff. They cannot socially distance from their patients or residents. And we also contested the efficacy or efficiency of ventilation systems in many of the institutions that nurses had to work in. You know, people's homes, for example, you can't rely on the air exchanges being adequate, and in many of the hospital and care home settings, clearly that was still an issue.
Did you ascertain any particular reason why the Scottish Government was wedded to the idea of droplet transmission?
And they said from their own literature reviews and their reviews of the evidence that it was droplet transmission. As my colleague said this morning, the RCN carried out its own literature reviews and engaged with experts, not only in the UK but across the world, reviewed literature, etc., and contested that view almost from the onset. Sorry.
No, please go on. When you were arguing for I suppose, a basis for PPE based on airborne transmission, in discussion with Scottish Government and in the various groups in which you were engaged, were you a lone voice on that?
No.
Can you indicate, without naming anybody, who else was of a similar view?
The other Royal Colleges, the medical Royal Colleges, the BMA, for example. There were other scientists who contested that view. So, yeah, and we contested the view around, carrying out CPR, for example, and we contested their definition of aerosol generating procedures, which was another trigger for higher levels of PPE if you were carrying out an aerosol generating procedure. We ourselves and other organisations wrote to Scottish Government to say that in terms of carrying out CPR, we considered that an aerosol generating procedure and staff should be given full PPE. Staff were expected to carry out CPR with surgical masks on up until the point of intubation, but that intubation is considered by the Scottish Government as an aerosol generating procedure, therefore they would need to wear FFP3 masks and full PPE for that. But, you know, you can carry out CPR for a length of time before the anaesthetist arrives to intubate. And if you're carrying out chest compressions, you're pretty close to somebody's face. So,
could you understand the basis of having full PPE at the point of intubation, but not at the point of carrying out cardiac pulmonary resuscitation?
no.
You also make reference in paragraph 36 to the RCN developing its own COVID-19 risk assessment resource.
Yes.
Members, what was that?
So the RCN worked with other stakeholders, and we developed our own risk assessment that is online. So it was to enable our members to be able to access what we considered the evidence base and their rights in terms of health and safety legislation, etc., in asking their organisations to complete risk assessments in terms of the level of PPE that was required, and that included things like ventilation changes. We did get a commitment from the Scottish Government that they would instruct employers to carry out risk assessments and make them freely available to staff within the clinical areas. And to date, I've not heard one nurse say that those risk assessments were made available to them.
What's your view on that?
I think if you're making an assumption that ventilation is adequate and that reduces the risk, if you're using ventilation within your hierarchy of controls and saying PPE is at the bottom of that hierarchy of control, that other methods are more effective, you have a duty to ensure those other methods were actually functioning and effective.
I see. You move on to consider the situation of transfer of residents or patients into or from care homes. And you look at this at paragraphs 39 and following. Mr. Pullman has already said that the RCN wasn't involved in the decisions on that, in the sense of the strategic decisions taken, not obviously the individual clinical decisions taken. The one thing that you do say at paragraph 39 is that you recognise the detrimental effect that restrictions on visiting had on residents and their families, particularly when they were suffering from dementia. That is obviously an area that this inquiry has heard so far a considerable amount of evidence about. Was that something that would have been obvious to you at the outset of the pandemic?
I think anybody who's worked clinically with individuals and their families, you know, individuals with dementia or learning disabilities, recognise the need for those connections in terms of their well-being, in terms of their human rights, I suppose. And if that wasn't able to happen, that it was going to have a detrimental effect. Elderly people can deteriorate quite quickly in terms of their physical and mental well-being, And I think for the residents in care homes, and not having that contact was clearly detrimental. But equally for elderly people who were then shielding at home as well, in terms of their physical and mental well-being, and the fact that their connections were severed would have a detrimental impact in terms of the level of frailty, etc.
Do you see a way around that problem, possibly through enhanced infection control procedures?
I think there was learning throughout the pandemic, and one of the main functions of CPAG that we touched on earlier was getting that feedback from staff who had expertise and experience of working within care homes, who, I have to say, my experience on CPAG is that those staff really advocated for their residents and their families in terms of trying to influence the guidance and take a different approach to visiting. It took some time for visiting restrictions to be lifted or eased, and different approaches were put in place by care homes, like, you know, in the summer months, trying to enable visiting outside, socially distanced, etc. So I think that they did try and address that. It was balance and risk, really. The risk of being socially isolated, not being able to see your relatives, and maintain those connections, to the risk of introducing an infection. As I say, CPAG was not a decision making, but it was there to influence the guidance, and the cases were well made from the sector.
Can I ask you for a personal opinion? Did you find that
I think
influence of what was being said at that stage compelling?
Yes. I don't think you can shy away from there were difficult decisions to make, and absolutely difficult decisions.
I suppose one of the elements that one has to factor into that decision is that if you have family members who are anxious to see their relative who may have dementia or maybe at end of life, and if you want to be able to get that person into a close environment with the resident or the patient, I suppose you have to have a degree of trust in the willingness of that relative or friend, whoever it may be, to do what is necessary to achieve that.
Yes.
And do you think that would be a reasonable request to make of somebody in that situation?
Yes. Yeah, I think if everybody made decisions and looked to see how they could minimise the impact on, say, their elderly relatives, so I would say it would be no different for those whose relatives were within care homes. You would do your best to protect them.
Can I take you to paragraph 42, please, for your statement? Could you just read that out, please, and then perhaps just expand on it a little, if you could?
Yes. So the problems care homes have faced during the crisis have, in many respects, been symptoms of how the sector and the people that live and work in it have been undervalued by society for far too long. So I said earlier that the RCN had campaigned for a long time prior to the pandemic to highlight the issues within the care home sector in terms of funding, staffing, skill mix. So there are two types of care homes. There are care homes with nursing and care homes without nursing. So social carers would provide the care within care homes without nursing. Care homes with nursing have to provide at least one registered nurse. And the reason they're a care home with nursing is that the residents have higher clinical need. Our premise was that clinical need was increasing over time, but in terms of the value that registered nurses could bring to that sector were undervalued for whatever reason. I think there is a systemic undervaluing of nursing knowledge and expertise, but particularly within that sector in terms of the clinical and nursing expertise that is required.
Has the pandemic done anything to increase that regard that may be had for that sector?
I don't think so. I think the sector is still facing the same issues. The number of registered nurses within the sector continues to decrease. And the feedback from our members who work in that sector is it continues to be that they work under significant pressure.
Now you give voice to a care manager, a nurse manager in a care home at the bottom of page 43. So it seems to me that is quite a significant quotation, and I'm sorry it's a slightly long one, but I wonder if you'd read it out for us, please.
Yeah, so my last week of nursing has been really challenging for me. I feel that as clinical lead and deputy manager that I have the skills and experience to carry out my job well. However, in the last week threw me a curveball, and even though I did everything I could possibly do to rectify the situation, it was unresolved and left me feeling rather hopeless and frustrated. It is very clear to me that there is still a blame culture towards care homes, and this needs to change. It made me question myself on why I actually do this job. It's thankless. The reality is I make a difference in people's lives every day. Sometimes I have to dig deep to remind myself of that. My background is A&E, high dependency, acute medicine and cardiac arrest team lead, and though it's through this experience that I'm able to do my role now. I use my clinical decision skills on a daily basis. I don't have a full ward of doctors to ask or 5 other nurses or nurse practitioners. I am expected to know everything about 55 residents and manage their conditions, as well holistic care for not only residents but relatives. Yet I am treated as if I am just a care home nurse. Can you manage a catheter? Will you manage to take a cannula out? I am the equivalent of a band 7 in a hospital setting, but often treated as a student nurse.
Yes. Now, as I indicated, the section on education and certification we're going to take as read, and some of my colleagues will look at that separately. But with that, could we go to your lessons to be learned? And again, these probably reflect much of what you've already said to us, but perhaps if you could just take us through what you think are the lessons that from your perspective need to be learned.
So I think one of the lessons to be learned is to recognise and value the contribution that nurses make to the outcomes within health and social care, and not undervalue nursing knowledge and expertise. And as I say, the impact that the safety critical nature of nurses and registered nurses, and not dilute skill mix to a detrimental level. We need a structured approach to workforce planning that ensures that we have the right number of registered nurses and support staff who do contribute significantly but do not replace registered nurses. It would be a failure if we don't learn the difficult lessons of the pandemic and tackle head-on the issues which have been in place for many years and probably in the too hard to do box. I think staffing decisions need to be driven by need and outcomes rather than finance. I suppose that's a fairly controversial thing to say, but I think often staffing levels are driven by finance and not actually clinical need.
Right. You say, perhaps, I'm not sure whether you quoted it, but in paragraph 62, you say, and it's in block, however, it is clear that in order for Scotland to be ready for the next pandemic and for the detrimental impacts to be minimised, the greatest lesson to be learned is to ensure that there is a suitable health and social care workforce in place.
Absolutely.
That's in terms of numbers and skills.
In terms of numbers and skills.
Yes. Right. Mr. McKenna, I think that's all I have to ask you. I offer you the opportunity, if there's anything you would like to add to what you've said, please do so.
I would just like to reiterate my colleagues' expressions of condolences to the families of those that were bereaved and impacted on by COVID-19 in terms of the families and for the nursing and other healthcare staff who were negatively impacted.
Yes. Those include nurses and healthcare staff who died.
Absolutely, yes.
Thank you very much, Mr. McKenna.
Thank you.
Yes, thank you, Mrs. McKenna. Very grateful. I infer from what is said, we may see you again. I'm sorry if we do.
Yes. Too good a job.
I think you may.
Thank you.
Thank you all. That's all for today. I'm very grateful to everyone for allowing us to go as quickly as we did.
Thank you a lot.
And 9:45 tomorrow morning, I think. Very good.